Well, this month is Breast Cancer Awareness Month, and on the Morning Blend, we want to keep that conversation alive.
When it comes to that awareness, treatment options are a big part of that. What advances are we seeing in breast cancer treatment? Yeah,
well, Dr. Margaret Block of Nebraska Cancer Specialists is on the Blend today. Good to see you, Doctor. Thank you. Well, and the timing is great. We got Race for the Cure coming up this weekend. I know you guys are taking a big role in that as well.
Yes, Nebraska Cancer Specialists help sponsor it, and I don't race anymore myself, but I like to go down and visit and see everyone else who is racing, and we help enroll our patients in the race. We pay their fee and all.
Oh, that's really cool. I like that. I'm going to be down there there's a team of us from the radio stations and from the news teams. I'll be down there. I haven't done it since, oh my gosh, high school, but what a great event. So
let's hope for good weather.
Yeah, no kidding.
Yeah, so much
absolutely.
This week.
We want to take some time while we've got you here. We want to talk about some of the recent advancements in breast cancer treatment. What are you guys seeing? What are you doing new? What are the latest advancements right now?
Well, as you know, progress does come slowly, but we've made a lot of advances in cancer in general, especially over the last 10 years. And in breast cancer, we have started to sort out many different kinds of breast cancer, so they're not lumped together as much in one group. And as we've sorted out the different types of breast cancer, we've gotten different treatments for different types of breast cancer. So for instance, we have drugs that specifically target the HER2 receptor, which is a growth receptor. Patients whose breast cancers have the HER2 receptor tend to have a more aggressive breast cancer. Those growth receptors literally make the cancer grow. And we have had a drug called Herceptin for many years now, starting early in the 2000s, but now we have other drugs available for the HER2 receptor. One of the newer ones on the market is pertuzumab. And we have a study actually using a new drug, which is very promising in the initial studies, which has a name, tucatinib. So there's a lot of advances in that arena. There's another type of breast cancer called triple-negative breast cancer, which seems to respond better to neoadjuvant chemotherapy, and some of those patients have a genetic mutation that they were born with called a BRCA mutation.
Sure. And there's the test for that. I mean,
correct.
A lot of them are getting tested for that.
Right. So if we see someone with triple-negative breast cancer, depending upon their age, but even if they have no family history, we usually do recommend that they get tested to see if they have a genetic mutation. And we know that some drugs may be more active in those patients who have triple-negative and have the genetic mutation. Some of the platinum drugs that are not new drugs, but they weren't really known to be particularly active in breast cancer before, but for this type of breast cancer they are. So just sorting out the different types of breast cancer and then some new drugs coming along, treatments have really changed. And one of the big changes in the last few years has been to give what we call neoadjuvant chemotherapy, which is a little different concept. So instead of going to surgery and finding out what stage you are, we do our best to do what we call a clinical staging without the surgical aspect other than a biopsy. And then if they have a certain type of aggressive breast cancer, triple negative or the HER2 positive, we often give chemo before the surgery to see if we can actually even eradicate it. Sometimes at surgery they don't find any tumor.
Now, you mentioned there's different kinds of breast cancer, and a lot of us don't. I didn't know that there were that. Do you know how many different kinds there are?
Well, it depends upon how you want to group them, of course.
Right, I'm sure there's
If you use some of the most commonly used tests, which is hormone receptor assay and HER2 assay, you would break them into hormone receptor positive, HER2 negative, hormone receptor positive, HER2 positive, and then the ones that are receptor negative, like the triple negatives.
Very different variations.
That's all over my head, but it sounds like it's just becoming very specific in how you treat a lot of these patients.
But we also can do a lot of genetic tests on their cancer, and the genetic tests on the cancer are not the genes that you're born with. And so there's a whole other classification scheme using those genetic tests, like basal cell cancer or luminal A, luminal B. Most people are not familiar with that. So that's, again, a refining of the types of breast cancer.
Now, you've been with Nebraska Cancer Specialists, you said, since 1990.
Correct.
Talk about the development in treatment and what's exciting about that. I mean, that's almost 30 years. I'm assuming things have changed dramatically.
Well, things have changed a lot, partly with these different types of breast cancer. We didn't have drugs that targeted HER2. In fact, we didn't even know about the HER2 receptor in 1990. So treatments have changed pretty drastically. We also do a genetic test on some of our hormone receptor positive breast cancers. That would be estrogen receptor positive and progesterone receptor positive. called an oncotype. If they don't have very advanced disease, they're a candidate to do this extra test on their tumor called an oncotype. And since using the oncotype, we probably give chemotherapy to about 30% less patients than we used to who have early stage breast cancer. So again, refining it has made the treatments much more specific for who needs more aggressive treatment, who needs less aggressive.
Yeah, there's no way, two ways around it. Breast cancer can be deadly, but it's not that devastating diagnosis it was 30 years ago. People are fighting this and beating it all the time. How important is early detection? I know we talk about this all the time, but I don't think we can beat this, beat this enough.
I think early detection is very, very important. The one caveat I would say is that we are now detecting some breast cancers that are very indolent, not very aggressive, and diagnosing them when they're only a few millimeters in size. So it's important not to overtreat them also.
Now we're running out of time here, but how can women be proactive in this? Not self-diagnosis, but doing those self-exams. Can you speak on that a little bit?
Sure. Well, I think first of all, to be proactive, people should maintain their weight and exercise. Exercise keeps up your immunity, and it does have anti-cancer benefit. Even if you're not an ideal weight.
So do healthy things.
Right,
Yes.
right. What everyone knows they should do, but don't do.
Right.
And then I think mammography is critical. As you know, the guidelines have changed a little, but we do have 3D mammography now that can really find tumors at only a few millimeters. And I still recommend people do breast self-exams. Unfortunately, a lot of times we find things much smaller in mammogram than breast self-exam, but women do find their own tumors sometimes.
You do. It's good to be aware. Well, let's go over. Oh, well, never mind, that went away. But thank you so much for your time today. Very important to be aware and
Nebraska Cancer Specialists. Well, you've got the website. There's a whole lot of resources up there for men and women when it comes to cancer. But Race for the Cure this weekend. I know you're going to be down there. You're taking a big role in that. So have a great weekend and good luck with all of that.
Hopefully no rain.
Yes, no kidding.
NebraskaCancer.com for more information. Thank you so much.
Thanks, Doctor. Thanks for coming. We appreciate it.